At the outset, I would now like to wish you all a very happy new year who are present over here, and to all of those who are connected to us online through the Zoom app. So this year we are back with the grand routes with a whole new look and a concept. So here is for you. So the concept of this year's Grand Rounds is going to be Year of the Masters, where we have expert speakers from various fields of ophthalmology who are going to come and present to you all. So to kickstart this year's talk, we have Dr. Atul sir, who's in charge of a retina department at the main branch here in Chennai. And our expert panelists today would be our beautiful ladies, Dr. Rekha and Dr. Jyotsna. Dr. Akbar sir is not available today because of some unforeseen circumstances, and Dr. Asher sir will be joining us shortly. So one thing about Atul sir is the way he thinks. So something like discovery consists of looking at the same thing as everyone else, but then thinking something different. So I just think Atul sir is one of those people who thinks differently, and he's going to walk us through his journey of macular hole surgeries today. And there's one more announcement to be made today, and the details of which will be given at the end of today's talk. This is the first of its kind initiative by our training committee at Dr. Agarwal's Eye Hospital. Further details, just stick on to it. I'll be giving at the end of today's talk. Thank you. So I'll call upon Dr. Atul sir for his talk.
Very good morning to all of you. Today we are going to discuss about SAIP technique, that is colored visco-suction assisted ILM placement in the macular hole surgery. And we all have started our medical school journey from Ganong to Robbins to Harrison. So I'll deal this topic in the same way: first physiology, then pathophysiology, and then the treatment part. So in this topic we are dealing with the two tissues. First is the retina, then the second one is the vitreous. You can see this is the one B OCT scan, and retina is composed of 10 layers, starting from the RP, then ISOS junction, then external limiting membrane, outer nuclear layer, outer plexiform layer, inner nuclear layer, inner plexiform layer, then ganglion, nerve fiber cell layer, and last is the internal limiting membrane. So few points just remember throughout this talk. The contour of the central part of the fovea is the U shape. There is no break. This is the straight line, ISOS junction and the external limiting membrane, and there is no break. The second one is the outer plexiform layer. It is at the level of the foveal contour. The second one is in this part is vitreous humor. The vitreous humor is 4 ml in the it's 4 ml, and it is composed of two parts. One is the central part, which is called as the vitreous cortex, and the second one is the second one is the posterior halide phase. Posterior halide phase extending from the this vitreous base. Anteriorly it is from the vitreous base till the optic disc. So it is composed of 98% of the water, and rest 2% it is chondroitin sulfate, glycoproteins and hyaluronic acid. So what is the fate of this vitreous? The fate of this vitreous is collapse, and which will lead to the posterior vitreous detachment. The collapse will start in the center, and simultaneously it will involve the separation of the posterior halide phase from the ILM. So we are going to deal with the vitreomacular interface diseases, which are vitreomacular adhesion, vitreomacular traction, laminar macular hole, full thickness macular hole, and the macular pseudo hole. Believe me, if somebody will start a lecture like this at 8 o'clock in the morning and he is going to deal with this 5 complex pathology, I'll just have one thing in the mind, that is quit the class with the tagline, go to hell, I'll read myself. But before doing that, just remember one thing: throughout the life we are not dealing with the 5 different pathologies. We are dealing with the different manifestation of one single pathology within and in the inverted comma, which can be present in a same patient, same time, on the different B scan. B scan means OCT scan, or in the same patient at a different time. So what is the parent pathology? The parent pathology is the anomalous PVD. The normal PVD is the central part will collapse, and the posterior part will separate from the internal limiting membrane. This will cause a normal PVD. This will happen in all of us. This is start usually at around the 20 years and complete at around the 78 years. But if the vitreous gel contraction, the contraction of the vitreous gel will outpace the detachment of the cortex from the ILM. This will lead to the vitreous gel contraction outpace the detachment from the vitreous cortex, or abnormal adhesion of the vitreous cortex with the ILM, or the combination of both. These three things. Then this will cause a traction on the retina, and this traction will cause the symptoms and the pathologies, all the 5 pathologies. The whole system was very confusing. In 2013, they formed a group, and which was headed by Duca, then Spade, then Dr. Seda. Total 9 or 10 ophthalmologists were there, and they have given a simple classification, that is by International Vitreomacular Traction Society group classification, and they have divided it, the vitreomacular interface diseases, into the vitreomacular adhesion, vitreomacular traction, full thickness macular hole, macular pseudohole, and lamellar macular hole. We will deal one by one. What is VMA? Only simple, in the simple sentence, VMA is perifoveal vitreous detachment, and this vitreous detachment will happen in all of us, with all of us. The only thing is, it is the stage just for the classification in which vitreomacular attachment is there in the central 3 mm part from the fovea. So, with perifoveal detachment of the vitreous, central attachment, and the third one is the normal foveal morphology. If the foveal morphology is normal and still the attachment of the vitreous is there over the retina, then it is called as vitreomacular adhesion. The same thing, perifoveal vitreous detachment, vitreomacular attachment at the retina, but if the foveal morphological changes are present, as change in the contour, normal contour is U-shaped, you can see it is above. The second one is intraretinal pathology. Intraretinal pathology as intraretinal cyst or elevation of the ISOS junction from the RP complex. So this is called as the vitreomacular traction syndrome. The third one is the macular pseudohole. Simple thing, it is the heaved up margin at the margin of the macular hole. ERM is present. This ERM will cause a centripetal traction. Centripetal means towards the center. It will cause the traction towards the center, and this will lead to a steep foveal contour. And always remember, there is no loss of retinal tissue in the macular pseudohole. The fourth one is the full thickness macular hole. In this, interruption of the all retinal layers from RP to ILM is present. This is the stages of the macular hole. I'll take one by one. It starts from stage 0, 1A, 1B, 2, 3 and 4. Stage 0 is same as vitreomacular adhesion. Perifoveal detachment of the posterior highlight with the normal foveal contour. Nothing is there. This is totally normal, but because of the classification, they have made it as a stage 0. Stage 1, they have divided into the 2 parts, 1A and 1B. 1A and 1B both are the VMT stages. In the 1A, foveal cyst is present in the inner part of the retina. There is no change in the outer retinal morphology. In 1B stage, there is foveal cyst extending till the outer retina. So, in the stage 1, there is no hole is present, only foveal cysts are present. 1A inside the retina and 1B whole retina. Stage 2, full thickness hole is present. This can be of various size, small, medium or large. Partial opening of the roof is there. You can see this is the partial opening of the roof is there. Vitreous is still attached to the margin of the operculum and partial PVD is present. This is stage 2. That means at this stage, vitreous is still attached to the fovea and to the optic disc. Third one is the stage, third one in which holes of various size, the same classification is going on. Posterior highlight detached from the fovea but it is attached to the optic disc. Everything is same, but that operculum, but this operculum is detached from the foveal side. In the stage 4, same holes of various sizes present, but posterior halide detached from here, means at the fovea and at the optic disc both. These are the staging of this. On the size wise, it can be divided into the small, medium and large. Less than 250, 250 to 400 micron and 400 micron plus. This is the arbitrary classification, and they have done this because in small, the success rate with the surgery and the chemical vitrolysis both is almost 100%. In the medium, it is less than the small one, and in the large, the success rate of chemical vitrolysis is very less, around 20%, but the surgical success rate with the ILM peeling is more, but not 100%. Last is classification by primary and the secondary. Primary is idiopathic, which is already I have told you, that is caused by the anomalous PVD, and secondary can be caused by the trauma, lightning, high myopia, schisis, PFT, and number of causes are there. So now coming on the treatment part. The treatment is, till 1991 nobody was doing the macular hole surgery, and GAS has classified the macular hole, and first paper on this surgery was by Kelly and Windle in 1991. They have just induced the PVD. They have just induced the PVD, and they have achieved the success of 58%. From 1991-1999, when Sipperle did the ILM peeling, the success rate was almost 50-60% was going on, and people have started doing this macular hole surgery. In 1999, Sipperle and group have removed the ILM, and they have proposed that this ILM is causing the traction over the retina, and removing the ILM achieved the success rate of around 90%. And they have given a paper in 1999, and paper was published in Ophthalmology Journal. 2004, they have classified this the hole closure. This is the journey of the macular hole. And 2004, they have classified the macular hole closure with type 1 and type 2. In type 1, they have classified there is no defect in the neurosensory retina with the RPE. But in type 2, they have classified it is into the two flat open and flat close, in which the neurosensory retina is missing, and still they were thinking that the closure is there. But then Dr. Naoruki came into the picture, and he has published a paper in 2010, and he used the inverted ILM flap technique for the large macular hole, and he just abolished the concept of the type 2 closure, and now all hole close only on the basis of whether there is a full neurosensory layer is there over the ILM or not. So he has given two papers, first in the 2010 with the classical internal limiting flap technique, and the other one is a temporal inverted internal limiting flap technique. And my journey started in year 2011, late 2011, when I started doing the macular hole surgery. I was very happy. The surgery was very clean and clear, and the holes were closing. The day before the surgery, the hole is there on the OCT scan, the patient can see, and after surgery, the hole was closed. The only problem was I was taking this type 2 closure into the consideration at that time. And I started doing this inverted internal limiting flap technique in the February 2015, and first few surgeries went very well, but the only problem I faced during the whole surgery, I found out the surgical technique was very difficult at the end of the surgery. It was very difficult to keep the inverted flap over the hole at the end of the surgery. I have tried n numbers of permutation and combination, and I have switch on switch off the infusion cannula, then tilting of the eye towards the optic disc, then half air, half fluid, everything I have tried. But every time I was going for the macular hole surgery, there was so much anxiety whether I'll be able to do in one go or not. Sometimes I have to do 3 or 4 times fluid air exchange in the same surgery. So at the same time, I have read about the Yuki surgery, and he has used this viscoelastic in autologous ILM transplantation. So I have decided why not to use this viscoelastic for the normal large macular hole surgery. So at the same time, the concept of dissociated optical nerve fiber layer defect means if the much you peel, the much is the defect inside the nerve fiber layer. The defect because of the trauma by the surgery. So I started doing the limited ILM peeling, and I was using this colored viscoelastic to put the flap over the hole.
None of the producers have any financial interest in the products of.
So this is my journey and of colored viscoelastic. In this I have done different type of flap with the help of the colored visco, and I have done the macular hole surgeries, large macular hole, and in these cases you will see the surgical flap was from 180 degree to 20 degree. How to see this viscoelastic during the surgery? To see this viscoelastic, I have just mixed a drop of brilliant blue, and I have used HPMC. I have used low molecular viscoelastic and put a drop of brilliant blue and colored it with it. This is 1 logmar visual acuity macular hole large. I have created a temporal flap with the finished blue. Then I am giving the radial incision because at that time I was more accustomed with this classical flap technique. So I have given a radial incision. I have put the colored viscoelastic on the temporal side of the flap, then tilt the eye toward the disc, and this causes the ironing out of the flap, and the visual acuity increase from 1 to 0.3. By this, after this, I have decreased the size of the flap, and from 180 degree, I have tried with the 90 degree of the flap, and in this case, 4 by 60 was the vision, 6 by 14 was the macular hole diameter. Again with the forceps, I have made a 90 degree flap. Be very gentle because you are dealing with the 4 micron flap and you don't want to tear it into the many part. So first from the one side, then from the other side, directly put it over the hole. Slightly massage, don't touch the RP because RP is the most important part in this surgery. Just place it with the help of the viscoelastic, temporal side, tilt the eye towards the disc and close the hole. And vision was from 460 to 636. After this I have tried 75 degree also. In this 557 micron hole was there. Again the same technique. With the finance loop I have created the flap. Again from one side, then other side. This is small bleeding is there because molar cell wrap the capillaries and damage of the capillaries there during the molar cell pulling. Just place it over the flap, over the macular hole, this flap, and put some viscoelastic on the temporal side where you have created the flap. Tilt the disc, and then at the end of the day you can see the U-shaped closure is there. But during this my 2 cases were failed, so I have gone back and revised my surgical technique, and I have decided that I will follow one path in which my 2 aims will be there. One is I'll do the surgery one time and I'll do the surgery in the easiest possible way. For this I have taken the help of the Newton and the surface tension law. Gravity, I have taken the help of the gravity by tilting the eye and using the color viscoelastic, and the surface tension which says the force of to separate 2 plates with the fluid in between is directly proportional to the area of contact. So the implication of this is I'll use a large flap. So this surgery.
Second case was 180 degree ILM flap without radial cuts.
Now I am doing this surgery with a large temporal flap preparing the flap with the help of the finesse loop first. Then from one side, I am just separating the ILM from the nerve fiber layer. Be very careful, very gentle, 4 micron layer, and you want a single piece. Just put it over the hole and then put the color viscoelastic on the temporal side, and the U-shaped closure will be there. So this is my study, and I have done till now 24 cases, but these are 20 cases in my study is there, in which 13 were females and 7 were males. Right eye were 13 and left eye was 7. In this study, you can see blue bars are pre-op visual acuity and the red bars are post-op visual acuity in the log mark. In all the cases, the visual acuity improved except this 6th case in which the glaucomatous optic atrophy was there. The visual acuity improved from 1.037 to 0.645 log mark. The macular hole diameter in my cases was 665 with the standard deviation of 189 micron. The base diameter was 1255 micron with the standard deviation of 306 micron. In my 20 cases, resurgery was done in 2 cases, and final result of 100% closure was achieved after the second surgery in those 2 cases. The last one is the laminar macular hole. Laminar macular hole is the classification of the characteristic of the laminar macular hole is the irregular foveal contour, defect in the inner fovea, intraretinal splitting at the outer plexiform layer, and the intact photoreceptor layer. These 4 are there. That means there is no full thickness macular hole, and this is the video.
With 618 and N8 vision, on nasal side typical epiretinal membrane, and on temporal side posterior vitreous detachment was present along with separation at outer plexiform layer. Following the extreme success of inverted internal limiting membrane flap technique by Michel Visca and extensive work by Chiode, surgeon decided to go for inverted ILM flap in this case too. The already given theory for lamellar macular hole formation is by vitreous separation and subsequent ERM formation leading to centrifugal traction. Surgeon has given a hypothesis that in tractional lamellar macular hole, main cause of vision loss is synaptic breakage at outer plexiform layer. Photoreceptors are most rigid cells in retina. Separation occurs at outer plexiform layer because in inner plexiform layer, more synapses per unit area are present. So if we remove this ERM traction and produce more pillars of Muller cells by ILM flap, that will lead to near normal foveal architecture and repeat synapse formation at outer plexiform layer. Surgeon started the surgery by intravitreal triamcinolone assisted PVD induction followed by posterior hyaloid and ERM peeling. After this, blind blue staining of ILM was done and peeling started with the plan to preserve a small piece of ILM for inverted flap. Unfortunately, ILM flap detached, so surgeon opted for plan B and took out a ILM piece and placed it over the hole with the help of color visco. After this, fluid air exchange was started. Just near the completion, surgeon found ILM flap was displaced from the hole and rolled over. So surgeon unrolled the flap with silicone tip cannula and perfectly placed it over the hole by the help of active suction of remaining visco from different directions. Surgeon named it as colored Visco-suction assisted ILM transplantation. At the end, air was replaced by SF6. After 1 month post-op, patient vision was 6/9 and N6.
In this LMH, pre-op best corrected visual acuity was 636 N10 and post-op best corrected visual acuity was 6/9 N8. So, Color Visco-suction assisted ILM flap placement technique is easy and reproducible. Thank you.
Thank you.
That was a wonderful talk there, and it's more like a struggle through these discoveries, right? So it's like a learning lesson for us. It's not like the first time you do something you're going to end up with success, right? It's like a lesson. You have to hear. I like our panelists to share their thoughts and their experiences. To start off, Dr. Rekha, because she's been handling all our surgical retina cases both in Hyderabad and in Bangalore, who was initially in Chennai. So today, start with Rekha. One more. Before that, I'd like to welcome our Master Blaster, Dr. Asha from Velachery branch. Welcome, sir.
Good morning, everyone. Firstly, I thank Dr. Atul for a wonderful talk and highlighting us from the basics of macular hole to the recent management of macular hole, the newer techniques and the inventions of it. This stimulates the PGs and everyone to put their mind into a newer inventions. So please be active in it and think something different. Second thing is, I have just two questions for Dr. Atul. One is, by doing vitrectomy, we release the anterior-posterior traction, and by removing the ILM, we just remove the tangential traction. Then what is the theory that you are involving the only temporal half of the ILM has to be peeled and has to be made as a flap?
Till now, nobody knows what is the exact mechanism of the macular hole formation. They have given the theory of the anterior-posterior traction. Anterior-posterior traction we relieve by the vitrectomy. The total anterior-posterior traction is relieved by the vitrectomy, and this tangential traction ILM formation, ILM theory is, it is causing the maintenance of the macular hole. So my hypothesis is, if you just put a flap, the flap will cause the gliosis, and this gliosis will lead to the closure of the macular hole. The theory behind preserving the ILM was, I don't want to touch the ILM because it causes, they have given a data that it causes the dissociated optical nerve fiber layer defect. Is still not known whether it is causing any visual disturbances, but small hyperreflective dots are there, then dimpling is there in the post op period of 2 years and 3 years. So my aim is to keep the retina as normal as possible and just close it with the help of the lid and cause more gliosis and near normal foveal architecture.
Sir, have you tried in traumatic macular holes and diabetic macular edema traction along with the traction?
Yeah, I have tried. I have done a 10-year girl and who has a history of macular hole from 3 years back with one ball injury, and the hole was very large. It was around 989 or 1000 micron. I have done the same surgery, same temporal inverted flap technique, and the hole was closed, and it's there in the slide also. The hole was closed and the visual acuity was also improved.
Also for an excellent presentation. With regard to your study, thank you so much for running us through your study also. So I just have a few queries with regard to the study that you have shared with us. For most of this, you said that the average hole size was around 1266 microns, plus minus 306 SD, right? That was the size of the hole?
No, first of all understand, what is the size of the hole? We are dealing not with the base diameter. We are dealing with the diameter which is the least lateral diameter in the mid part of the retina. So I'll just show you. We are not dealing with this 1593 micron. We are dealing with the most lateral part, least lateral part in the middle part of the retina. That means this is 1215 micron. And in my study, the size was, the minimal hole diameter was 665 micron.
Okay.
It is not 1000 micron.
So you don't look at base diameter anymore, you're looking more at the least possible diameter per hole closure.
No. This is the general consensus. We are not looking at the base diameter. Yeah.
Okay. Sir, the second thing is, did any of these have, did you take duration of the hole into account, or it was just size?
No, I have taken just the size into the account,
So,
not the duration.
whatever may have been the duration of the macular hole or the symptoms, we've still gone ahead and offered the surgery.
Yeah.
And that, so our classical teaching that duration of hole you feel does not have any impact anymore on hole closure rates.
No, it's not like this. I have taken consideration of all type of holes of all duration.
Okay.
Irrespective. My aim is just to show that hole closes with the temporal flap technique, and the easiest way is to go with the colored viscoelastic.
Okay. So what we do show, in fact, in the study is that whatever be the duration, with this technique you did still achieve a hole closure.
Yeah.
Okay. So the second thing I wanted to know is, there were some cases where you do a 180, some cases where you do 90 degrees. Is there any specific indication where you choose which one, how many degrees you want to do?
No, previously I was doing, means till 2000, start of 2018, I was very young and I was trying everything at that time. But in the last 1 year, I was trying everything. I want to preserve the ILM, I want to close the hole, I want to increase in the visual acuity. But in the last 1 year, I found out that I cannot do everything. By no surgery, 100% hole closure is possible. My aim is, not my aim, everyone, all the people who are doing the macular hole surgery, the only aim is to find out a simplest technique to close the macular hole, which can be used by a person who is 1 year experience in the retina or 30 years experience in the retina. The experience should not matter in the surgical technique. So because of that, I have found out the easiest, from my point of view, this is the easiest possible way at this time to go for the macular hole surgery.
So we do not have any indication that here I'll peel 180, here I'll peel 120, here 120.
Previously I was doing, that's what I told, previously I was doing, but from the last 1 year, I am using only 180 degree flap.
So then just one last question, the two cases where you said you had to do a resurgery, what was the technique that you
the same technique I have used, minimal ILM peeling, and in both of the cases, the peel was around 60 degree. And I was not able to find out the flap in the second surgery, so I have done again the 180 degree flap and the hole was closed.
So the remaining 180
remaining, yes.
Thank you.
Thank you. Dr. Ashraf, and we have you tried, familiar with this technique for macular hole surgeries? And
first off,
how was
I
yours?
say that is a fantastic presentation. He has gone through the beginning, the mid and the future of macular hole. He has done some amazing work on macular holes. It's really good. And he's like almost the king of macular holes, especially when it comes to Agarwal's group. Any macular hole, please refer to him. Okay. Second thing what I wanted to ask was, you said 60 degrees flap when you went to failure in two cases. Do you think it has anything to do with the amount of ILM that you are relieving from the whole area, relieving that amount of traction?
No, in fact,
as ILM is the elastic layer on the retina which is pulling the retina towards tangentially, which is causing that hole. So do you think relieving that pressure on 180 degrees of the macular hole is the reason that you are closing that hole?
In both the cases, I was not able to find out the ILM flap in the second surgery. So my hypothesis is the ILM flap displaced in the after the surgery and the hole was not closed. To keep the ILM flap, the only point is to keep the ILM flap for the 1 day, at least 1 day over the macular hole. I have started doing this 180 degree flap because the surface tension will allow to keep the flap over the hole because the area of contact is very high.
Second thing is, what is the rationale for using the viscoelastic?
The viscoelastic is doing nothing. The viscoelastic is making your surgery easy. When you are doing the surgery without the viscoelastic, the temporal flap technique, and you are just tilting the eye towards the disc, and you are doing the fluid air exchange, the flap is coming over the hole. At the end of the surgery, sometimes the flap goes this side or that side, and it is not properly covered with the hole. So you need one technique which is more reliable and more controllable. You can control it more precisely. For this, the color viscoelastic help. The technique is little slow than the normal fluid air exchange, but you can apply this in the ILM transplantation also. It's very easy. Once you learn this technique, it's within a couple of minutes. You just need a patient, color viscoelastic and a cup of coffee. After putting the viscoelastic, you can have a cup of coffee also, and half an hour wait, and then you can proceed with the surgery. The flap will not move. If the flap is large, color visco is there, the flap will not move, and most of the time, 99% of the time, it will not move, and you don't have to go for the second surgery.
The reason I'm asking is I agree with the concept of using color visco or any kind of viscoelastic when you're doing an ILM transplantation. But when you're doing an ILM peel and you're doing a limited peel where the ILM is still attached to the retina, the chances of it actually displacing are very less. So you can actually just do a immediate fluid air exchange, a controlled fluid air exchange, and you won't have any of the viscoelastic to trouble you.
Sometime in vitro talks are not as in vivo surgeries. So the flap moves because the movement of the fluid is very fast. When you are sucking the fluid, sometimes the flap displays from one side or other side. You want a proper flap over the hole till the end of the surgery, and not till the end of the surgery. It should be there till the end of the first day. So they are using the air also, and the concept is the flap should be there at least for 1 day. After that, gliosis will be there.
Have you tried double ILM?
Because
this reduces the use of visco. The flap which is there will not be free. It will be attached still there.
I am not getting double.
However, you're like the double flap. You can dub the other part of the ILM, and the second flap will be over the macula.
I have tried. It's a very difficult technique to keep one flap from one side, the other flap on the other side, because both the flap will move and the hole will not close.
But the ILM is still attached there, so you don't require it.
It's not an easy technique. I have tried it. What I have tried, I have just removed the whole ILM, and I have kept 180 degree, around 90 degree of the ILM attached to the hole margin, and keep it over the hole. But it's not easy.
Probably that's one of the other techniques which surgeons over the globe use. Yes,
so basically you are saying with the viscoelastic the ILM is closed.
Yes.
So is there a need for positioning of the patient post-operatively or not? You say it is staying. So is there a need for post-operative positioning?
Still the answer is not clear because most of the people now started doing the surgery with the air only, and the positioning is required only for the next 24 hours. I have not done even a single case with the air, but people are doing with the air only. And what air is doing? This is creating a scaffold which make the macula dry. The dry macula, because of this dry macula, the movement of the glial means molar cell from the retina into the whole space, and they will form attachment. And this swelling of the molar cell and migration of molar cell from the healthy retina in the whole space, this will cause the movement of the photoreceptor centripetally. Only because of the centripetal movement of the photoreceptor, they have given the Michel Vesca has given the hypothesis that because of the centripetal movement of the photoreceptor, the visual acuity improves in the macula hole surgery. So it's like this only.
We have other queries from our online app. So does viscoelastic have any different side effects post-operatively? Do we have to look for those?
No.
Okay, and is there a recovery period change with or without visco usage?
No, this viscoelastic only decreasing the anxiety and the surgical time during the surgery. Nothing on the post-operative period.
So it's for the surgeon?
Yeah, it's for the surgeon. If you are not able to do the surgery properly, you have to use the viscoelastic.
So what are the other techniques which probably people around the world do for the panelists, the questions for the panelists from the online thing? As Dr. Rekha said, probably the double IML technique, yeah?
So many. They use autologous blood clot. They've tried lens capsules. So many procedures are there.
You have used amniotic membrane also.
What about 3?
Autologous retinal transplant also has been done.
Autologous?
That is also done. ILM, blood, capsule and autologous retinal transplant has been done for the larger macula.
Is there a grading change? I mean,
those are.
Is there a grading change? So supposing if it's at stage 1, 2, or which stage do you start using an inverted flap or not use? Sometimes you don't have to use.
No. It depends upon the size of the macula hole.
Yeah, so what's
the size of the macula hole. Usually I go with the 550 or above, not below that. Previously I have done few cases with the 400 also, but in those cases I have used the limited ILM flap technique. I have not removed the whole ILM. So nowadays only 550 hole with the temporal ILM flap technique.
What about this technique in a retinal detachment with macular hole?
Retinal detachment with the macular hole, I am just doing ILM flap. I am just peeling the ILM, making a hole on the nasal side, just taking out the fluid from the nasal side from the hole, and the hole will close by itself. The other thing is, I have tried of using the same ILM flap, same ILM technique here also, but I don't think it's of any use because we are seeing a large hole during the detachment part. The hole is small and we can just rub the margin of the hole very gently with the help of the silicone tip cannula, and the hole will become small during the surgery also. So I am not doing the ILM flap technique now. Previously I have tried.
Any questions from the audience? Any other questions? Dr. Probably that will be the last question for today.
This question is not about your technique. It's just from a patient's perspective. I have a patient with say a 10 to 15 years duration of a macular hole, coming and asking me like what would be the benefit for me if I undergo surgery now, because previously I was told that the vision improvement may not be great. So how do I motivate the patient?
15-year-old macular hole, no. First of all, always remember, no retinal surgeon can give any guarantee about the visual improvement. It can be there, it can be no. So what is in our hand is just to close the macular hole. And by closing the macular hole, at least we can decrease the size of the scotoma. And nobody can give guarantee that the vision, even if the vision is 618, it will go to 6.9 or 6.12 also. Maybe it remains 6.18 and maybe it go for the 6.9 also.
I think a better way for you to counsel the patient for that would be to prevent a macular hole detachment, which would lead to a worsening of vision, and that vision, once the macula is detached, the vision will never come back even to what it is existing. So it's basically, most of the retinal surgery that we are doing is basically to preserve the vision. It's not usually to gain vision. So that's part of retina counseling when it comes to it. We don't counsel that you're going to gain vision unless it's a detached retina and you're attaching it where you might gain little vision. But other surgeries are mostly to preserve the vision as it is.
Actually, in the case of macular hole, we counsel patient in two ways. One is anatomical closure, that we can show it on OCT, the hole closes post-op. Second thing is the visual prognosis. And visual prognosis, it depends on the factors what we consider. And second thing is, in most of the studies we have seen, first 1 or 2 months we don't feel that much of improvement, but after 4-5 months we surely get 1 or 2 line improvement in it. Immediately after surgery we have put the gas, so you can't give any improvement to the patient. So after 4 weeks, once the gas completely gets absorbed, he'll have some improvement, that will be about 1 line, and later on 3 to 4 months he will get 2 to 3 lines of improvement. And most of the studies have proved this also, that it's a slow process. As the glial tissue comes and covers up and later on covers the whole macular hole, that time we'll get a good visual prognosis.
One more thing, Dr. Atul. What is the implication of the usage of different types of gases? Do you go with the different surface tension which is applied by each of the gas SF6 and C3A?
No, at this time I am using only the, previously till 2014-15 I was using the C3 effect, but now I am using the SF6 only, but I am trying to switch over to air. No difference. You need the air to close the macular hole just for 1 day. Because I am scared, I am not capable, that's why I am using the SF6, otherwise I have to use the air only.
Do you think that if I would take like a 600 micron macular hole and I would use a conventional ILM peel with a C3A gas, the visual acuity would be better 1 month post-op than if I use an inverted peel with SF6?
In fact, there is a study in the AO last month also. They have 665 micron they have taken, and they have shown that the visual acuity is much better. But it's all in the process. Maybe inverted ILM is not required till the 600 also. But because till now everybody is taking 400, the cutoff criteria, I have started from 550 or 600. So maybe after some time people will increase the criteria from 400 to 600 or 700. It's depend with the time.
Super, great job, Dr. Atul. Thank you.
Thank you, Dr. Atul sir, for this wonderful talk and our great job by our panelists today. So big round of applause for all of them. So before we conclude, as I was telling, there is an announcement at the end of this today's session. So there is something, a new thing, a new innovative by our training committee, something called as the Wet Lab Pop-Up. This is the first of its kind initiative by the training committee to impart surgical education to his in-house consultants, residents and fellows. It's probably going to be open even for the consultants outside Agarwal. So this is going to be on a first come, first serve basis where they can have surgical training. It's for a 1 hour session. It will be chargeable and the registration is mandatory before 15th of March. So various techniques like for tunnel, SICS tunnel